Welcome again. Hello again. I would like to meet you again. Welcome the professors, the experts during the next last session today and all audience. I would like to welcome the first lecture. It will be Professor Can Gönen from Turkey, Istanbul, who will tell us about the EUS assessment for vascular system before pancreatic surgery. Welcome, Professor.
Thank you very much, Professor Kozlowska. And I think I'm trying to share my screen. Let's find it. Yeah. Okay, I think this session will complete the previous sessions, and the title is well chosen for this program. I think you can see my slides, right?
Yeah, very well.
Okay. First of all, I would like to thank the organizing committee for the kind invitation. Today, our title is EUS Assessment of the Vascular System Before Pancreatic Surgery. Why this issue is important? Because Professor Nakai already discussed the ability of EUS for detecting pancreatic cancer with a very high sensitivity, especially for small lesions less than 2 centimeters. And EUS is also useful for nodal staging. Okay, but vascular invasion is very important for us because to increase the survival of pancreatic cancer patients, you need R0 resection. And before resection, you had to know details about the vascular infiltration. So this is the main topic of this lecture. My agenda is first to identify important vascular structures and how they look like when there is infiltration, and the diagnostic yield of EUS and when to use it, and some important vascular problems, not tumor related, but we had to know before pancreatic surgery. Let's begin. And where to look for? Of course, we had to systematically investigate the portal veins, superior mesenteric veins, hepatic artery, and gastroduodenal artery. And the first question, have to find the celiac artery and the SMA already mentioned. Go into the stoma, find the liver, then clockwise, and you will see the aorta, the celiac artery, and the SMA. And this is a leaf demonstration. Go on. This is the aorta, the celiac artery, and this is the SMA. Okay, when there is infiltration, as shown here, this is the infiltration of the celiac artery. Of course, the tumor is bigger, but this is part of the tumor. Okay, when you go a little bit, the celiac artery has divisions. As you see, splenic arteries go upwards, hepatic artery downwards, and sometimes you see left gastric, many times you see left gastric artery going towards the left of the screen. Okay, let's see it in real life. This is the aorta, this is the celiac artery. The one goes to the left is the left gastric artery, the splenic artery goes upwards, and the hepatic artery goes downward, and also you see the portal vein. This is the hepatic artery going downwards towards the portal vein, and then if you follow it, it will reach the hepatic hilum. Okay. Could you see my arrow cursor? While showing? I hope. Okay. This is the celiac artery, and this is the tumor. Tumor is infiltrating the celiac artery, and at the area where the splenic artery goes upwards and the hepatic artery goes downwards. So, as you see here, the hepatic artery and splenic artery involved. But if you look at this example again, you see that this is the tumor, and the tumor is also infiltrating the SMA at the down side of the screen. Okay. Following splenic artery and vein, already mentioned in a previous section, first find the aorta, and if you turn clockwise towards the tail of the pancreas, you can easily follow the splenic artery. Let's see it in real life. This is the aorta, celiac. Splenic artery first goes upwards, and then it turns there in many times. You will see, yeah, it turns again, and now you follow it at the level of pancreas, and this is sort of splenic vein. And here it's at the tortuous course. It turns again, and then it goes to the splenic hilum, and also you see the splenic vein. You can do it in the counterclockwise direction. And how it looks like from the bulbous, and to get this view of the liver, you had to go extreme counterclockwise rotation while in the bulbous. Here you see the segment 5, 8, segment 6, and 7 branches of the portal vein. When they combine, this is the right posterior branch of the portal vein, and this is the left branch. At the bifurcation, you see the hepatic artery here. And hepatic artery comes towards the left and then turns, and it travels toward the aorta, but before going to celiac, it units with the splenic artery and then with the aorta. This is the way how we follow hepatic artery in the bulbous. To see static images, this is the portal vein, the splenic vein, and SMB, and you see the hepatic artery. Common hepatic artery, when it gives gastroduodenal artery, goes towards the liver as hepatic artery propria or proper hepatic artery. And on the left side of the screen, you see the tumor involving both the hepatic artery and the confluence of the portal vein. And this is one of our cases. There is a big tumor here, and it infiltrates the portal confluence, and also it infiltrates the gastroduodenal artery. You see top on the left side, right side of the screen, sorry, and it also affects some part of the common hepatic artery. So this patient has dual vessel infiltration. Another case, let's see it in dynamically. This is the tumor, and there are two vessels at the inferior side. Here you see one of them is the superior mesenteric artery, and the other one is superior mesenteric vein, and you see the confluence here. So it affects the confluence in this case. If we watch it again, this is the SMA, and the SMA is also infiltrated by the tumor. This case infiltrates both portal vein and also a small part of the SME, superior mesenteric artery. Okay. And this is another case, how we do it systematically. This is a case of tumor with cystic change at the head of the pancreas. This is the tumor. And you see a dilated bile duct, choledoch, and you see infiltration of the gastroduodenal artery, and you see infiltration of the CMB, but as you see, CMA, superior mesenteric artery, is intact. And this picture is better. It shows that it is portal vein and portal confluence is infiltrated. So you have a case with pancreatic mass, portal vein, confluence, SME infiltrated, gastroduodenal infiltrated, but SME free of tumor. If you want to go with surgery with this kind of cases, you had to be ready for a portal vein reconstruction. Indeed, this is the picture taken during the operation after removing of the tumor and the pancreatic head region. You see the portal vein with, of course, reconstruction. And this is another case, 30-year-old male presented with abdominal pain. There is a big mass in the pancreatic tail infiltrating the spleen, and it also infiltrates the splenic vein and artery. As it obstructs the splenic vein, you see the fundal varices in the photograph, and this, unfortunately, this case has metastasis in the liver with some cystic degeneration. But also, this case, you see from the stoma a very big, thick portal vein, sausage-like, with full of thrombi. You see the portal vein thrombosis. When you turn to a clockwise, you see the mass itself infiltrating the splenic vein. And also, you can see the collateral vessels around the portal vein, as shown in the Doppler. Okay. If you see this, if you examine this portal vein from the bulbous, you see that this is the portal vein thrombus, and these are the collateral vessels. Here you are. And if you put Doppler, of course, you get a venous flow in these collateral vessels. And we get a biopsy from this case, but in this case, biopsy from the portal vein thrombi itself. Here we are getting the biopsy from the portal vein, and the diagnosis was neuroendocrine tumor, well differentiated. Why we get biopsy from this from the portal vein, not instead of mass, is because there was so much collaterals around the mass in the fungal region, so we do not want to induce a variceal bleeding. And also, this tumor was removed from the primary tumor. It can be, of course, a tumor thrombi, or it can be a blunt thrombi, which I will mention in a minute. But biopsy from this thrombi shows that it is a tumor thrombus, and the diagnosis was neuroendocrine tumor. A few words about EUS-FNA for thrombosis. When we have a thrombosis in a vascular system, there are three scenarios. First one is tumor invasion. The second one is this can be a removed malignant thrombi, localized a distance from the primary tumor. You cannot see the connection between the tumor and the thrombus, but it can be malignant. And the other one is a benign or blunt thrombi. And there are some series, and if you perform EUS-FNA, in these cases, the diagnosis can change. It can be upstage, or sometimes it can be downstage. And of course, contrast and elastography, contrast enhanced ultrasound or elastography can help. If it is a tumor thrombosis, we are waiting that it had to be hard, blue, in other words. If it is a benign, normal, blunt thrombosis, you see that it's mainly green. What about our case? Indeed, decision is a little bit difficult. This is the elastography of the thrombi. It looks like, let's say, green, but the biopsy is totally malignant. In many times, we need more studies about this, the use of elastography and contrast enhanced for this indication. And please do not forget the investigation of SMA and SMB. And this is from the second part of the duodenum, you see the SMB here, and this is SME, and you see also the pancreatic duct and aorta on the other side. How it looks like when there is tumor. Yes, this is a tumor, big tumor, in the hepatopancreatic region. It causes pressure over the SMB, but not infiltrating it. And also, if you see, SMA is intact, going at the downside of the tumor. Okay, we had to talk about this recent paper. I think it's important. It's about the use of elastography for differentiation between tumor infiltration of a vessel. The main idea is if two tissues have different hardness, and if you give a compression, the border between tumor and the vessel will have a green hue or different color if there is no infiltration, because the tumor is hard, the vessel is not hard. In other words, the elastography is different. So if there are differences between elastographic parts, the intervening section has a different color. In contrast, if the tumor infiltrates the vessel, they move simultaneously, resulting in no artifact. Let's see examples. The upper one is there is no infiltration. This is mass. This is the vascular structure. And when you put elastography, there is a colorful band in between. The second one, the middle one, there is infiltration of the vessel, and as there is infiltration of the vessel, it moves blockly, and there is no band in between. And the last one, although it looks like it is infiltrated, when you put the elastography, there is a bump in between the vessel and the tumor, so it is benign. By using this, you can reach very high sensitivity and specificity and also accuracy when compared to just B mode or when compared to CT. So the second issue is what is the diagnostic yield of EUS and when to use it? Indeed, Professor Nakai already mentioned them. I will skip them, but it's very sensitive for vascular involvement. And also, Professor Nakai already talked about the NCCN guideline. So we have resectable cases. In typical cases, we don't need biopsy in our practice. If classically typical, we go with resection. But for borderline cases, we get biopsy before neoadjuvant treatment because we will give neoadjuvant treatment. So we have to get biopsy. And EUS at this stage generally we use it as decision making because sometimes CT shows CT cannot clearly show if there is infiltration or not. There are ambiguous cases, so we use EUS for decision to help decision. So it is not relying on EUS, but using EUS complementary to CT is mandatory for these cases. And if the case is unresectable, of course, we need tissue biopsy to give chemotherapy. And also there are other classifications. We are also using International Association Pancreatology classification for borderlines because it includes anatomic, biologic, and conditional conditions, which Professor Nakai already mentioned in his excellent lecture. And the answer is, according to this small study, yes, there are very few reports about this area because after chemotherapy, CT cannot reliably differentiate if there is residual tumor or if the tissue around the vascular structures is just fibrosis or inflammatory reaction. Yes?
Excuse me, Professor, we lost your share of your screen and we don't follow your lecture, only we are able to follow.
Okay, I can again share.
Please.
That's fine. For how long are you watching just me?
Only just a moment. Just
okay.
a moment.
Okay. Can you see it?
Not yet.
Can you see it just now?
We see changed, yes.
Okay. After neoadjuvant, if there is suspicion about tissues around vascular structures, you can also get biopsy, and this is a high sensitivity. The last session, because I have just 4 minutes left or 2 minutes left, important vascular problems that should be known before surgery. I will show a case. This is an old lady with a small tumor shown as asterixis and a dilated pancreatic duct. But we have noticed that there is a very prominent gastroduodenal artery. It was really unusual. And what is also interesting is that
Excuse me once more. We see the computer, but we don't see the lecture, yeah?
Okay, let's try to do it again.
Full screen, please, full screen.
Full screen?
Mm-hmm.
Sorry, I had to share again, otherwise it's blocked. Okay.
Oh, yes.
Okay.
Okay.
The last case, and I will finish in time, in 2 minutes time. Sorry. I think I have 2 minutes, right?
Okay, welcome.
Okay, this is an old lady, and we see the tumor here, the dilated pancreatic duct, and we have noticed a very prominent gastroduodenal artery. It's really big, thick, and the flow is indeed towards the liver hilum. It's what we are, reverse of what we are expecting. So we think, what is the reason about it? The reason is indeed very obvious. normally, blood comes from celiac artery towards the liver, and the SMA, through SMA, anterior and posterior pancreatic duodenal arcs supply and unite with these structures. When there is celiac artery stenosis, blood no more coming from the celiac towards liver. All blood is coming retrogradely from SMA through a thickened gastroduodenal artery to the liver. And why is it important? Because you cut during the pancreatectomy all these collaterals. So what we did, we protect these arcades. This is the anterior posterior duodenal arcade and gastroduodenal artery. That's why we protect these collaterals, because the celiac artery is totally occluded in the patient. And this is the angiographic appearance, no flow from the celiac, all flow coming from the SMA retrogradely, so causing a very thick gastroduodenal artery. So we have to think about celiac artery stenosis because they are old patients and the prominent gastroduodenal artery is a clue. And the last thing is, do not remember to identify not tumor-related emboli or thrombi, like pulmonary emboli or other embolies in vascular structures, because as we know, pancreatic cancer has a potential for thrombotic events. And in summary, please examine the vascular structure systematically. It's preferable to perform EUS proactively, in which cases diagnosis with CT is difficult or ambiguous. And please do not forget to explore other vascular problems like celiac stenosis or distant emboli. Thank you very much for your patience.
Okay, thank you, Professor Jan. We will have a discussion time later. So let's move on to the second speaker. The second speaker is Professor Pradam Chai Kongkang. He's my good friend, and he is now the president of the Thai Association for GI Endoscopy, TASE. So he'll talk about the EUS cystic lesion. So please start, Pradam.
All right. So thanks the organizing committee very much for having me talk in this topic. And thanks Professor Anna and Professor Nagai. My talk today is about cystic pancreatic lesion, milestone of diagnosis and treatment. So because audience of this conference, some of us might be beginners of the endoscopic ultrasound world. So let me start some background about the pancreatic cysts. I mean, most of us know very well that currently the incidence of the pancreatic cyst has been increasing. It's not truly increased, but because we might do more screening image or surveillance image, so then we can detect more cystic pancreatic lesions. So the true incidence, which will be around 10 to 15%, and the vast majority of the cystic pancreatic lesion, they are asymptomatic, and they come to see us because they just those pancreatic cysts just been incidentally identified by various kinds of images. So and also the other problem is that the classification of the pancreatic cysts are different. In my practice, I would prefer this classification, which doesn't cover all kinds of pancreatic cysts, but cover more common pancreatic cysts that we commonly see in our practice. The first group is the non-neoplastic cyst, which is pseudocyst. For pseudocyst, I mean, everyone know very well, no chance of the malignant change, so it's truly benign. And the second group is a benign neoplastic cyst without malignant potential. It's not a pseudocyst, but the wall lining the cystic pancreatic cyst is a true cells. But those cells, the chance to develop malignancy is very low. It is a cystadenoma. And the third group is a benign neoplastic cyst with malignant potential. And for branch duct IPMN, this is the most problematic one because it has varieties, length of changing to the malignant cystic pancreatic lesion. And the second one is mucinous cystic neoplasm, which has about a 10% chance to develop to be high-grade dysplasia or cancer. And the solid pseudopapular neoplasm, which again has about 10% chance to have aggressive tumor behavior. So if we see some mucinous cystic neoplasm and solid pseudopapular neoplasm, and if we can make a diagnosis, we don't want to leave them to patients. And the fourth group is a malignant cyst, which is main duct IPMN, which has 70% chance of high-grade dysplasia or cancer. So this kind of cyst, certainly we cannot leave it to the patients. So this is a background that some kind of cysts we can leave them alone, some kind of cysts we cannot leave them alone, some kind of cysts we need to do the close follow-up for that. So how many modalities that we do have to make a diagnosis of pancreatic cyst, because it's very important. If you don't know specific kind of the cystic pancreatic lesion, so then you don't know exactly what you're gonna do with that kind of cyst, leaving or cutting or ablation, we don't know, right? So what do we have? We have ultrasound. Ultrasound is very common. It's good for screening, but it's insensitive and they provide limiting information. So practically, we wouldn't use ultrasound for that. It might be the most common image that identify incidental found cystic pancreatic lesion, but after that, it's probably useless. CT we also use, but CT in comparison with the MRI plus MRCP. MRI plus MRCP is better. It's not only no radiation, it's not only that T2 can show communication with main pancreatic duct, but because of its technique, so that it can differentiate between solid and cystic pancreatic lesion very well, and it's also good for following up. For ERCP, for diagnosing pancreatic cyst, at the very least, in my practice in Thailand, and I think most countries in the world, we don't often use ERCP for an evaluation of the pancreatic cyst more like in the past. But in Japan, I heard that they still use in some cases, particularly small cysts that might be difficult to do the FNA. For EUS, we can divide into the non-FNA EUS and also the FNA or FNB EUS. So for the only EUS alone is non-invasive and it's good. It's relatively non-invasive and it can give us more information regarding the pancreatic cyst. And sometimes if we found characteristic finding of the cystic pancreatic lesion, then we can make a diagnosis with confidence. For example, if we can show honeycomb appearance, we can make a diagnosis with high certainty of serous cystadenoma. Regarding this topic, Professor Chris Kaur from Singapore will talk about this topic in tomorrow. So if you want to listen more, so please follow Professor Chris Kaur tomorrow. However, limitation of the EUS morphology alone, it has moderate sensitivity and also specificity as well. And also there are problem of inter-observer agreement. So that's why we sometimes need to go to FNA. So FNA is needed in equivocal case. And what we will look at the specimen that we obtain from the FNA specimen, typically we look at the viscosity. And viscosity show very short length of the string size, so that it's likely serous fluid. But if it show the very long string size, longer than 3.5 millimeter, it suggests a mucinous lesion. So then that can help us in some situation as well. And cytology can help us. Unfortunately, the sensitivity of cytology is very low, particularly in the small cyst. And then no mural nodule, so you have to puncture, you have to do different technique, try to aspirate before even that, the sensitivity is still low. chemistry, we look at the CEA, we look at the amylase, but generally the accuracy is around 60%, and tumor markers and molecular arrangement. And most of the time, FNA for cystic fluid analysis getting more difficult if cyst is smaller than 1.5 centimeter in diameter. So then, as I discussed, so then if we can identify typical findings of the cells obtained from the cytology is good, but if we cannot, it wouldn't be helpful for making a diagnosis of that cyst in the pancreas. So, to my opinions and my review, at this time, I think that after we have listened to previous slides, then now we know that EUS morphology alone, non-invasive, and analysis from cystic forensics, they all have some limitations. And there are three methods that I can say it's like a three musketeer in this era that provide a high yield for making diagnosis of the pancreatic cyst. The first one is a molecular analysis, and the second one is EUS guided needle-based confocal laser endomicroscopy, and the third one is the microbiopsy forceps. Because the later tools, NCLE and microbiopsy forceps, they can provide us the two images of the cyst. One from the viable image, confocal, and the second one is the image from the dead tissue. But because of the accessory or the equipment, so we get higher yield for that. So we will go in more detail for these three strategies. So for molecular analysis, what we want to know for molecular analysis, we want to differentiate between mucinous and non-mucinous lesion, and particularly for the IPMN and other types of the cyst. So there was a recent systematic review and meta-analysis published in GIE in 2021. This systematic review recruits 6 studies from 785 lesions. And for IPMN and mucinous lesion, which we want to know, that the combination of KRAS plus GNAS mutation had significant higher diagnostic accuracy than KRAS alone or GNAS alone, significantly. And the pool sensitivity, specificity, and accuracy of both combination for diagnosis of IPMN was very high, more than 90%. And they each significantly higher compared with CEA alone, significantly. So then looking at the results of this systematic review and meta-analysis is, I think, is give us a very good hope that if we use this method, probably can help us to differentiate types of the pancreatic cyst very accurate. So then the second one is EUS NCLE. For EUS NCLE, let me show some case of my practice. This is 56 male who came to see me because of idiopathic recurrent acute pancreatitis. I did an investigation and I found a small cystic pancreatic lesion around the head of the pancreas. With the morphology from the MRI, we don't know exactly what is cyst that. And when we did the EUS, the cyst is very small. It's too small to aspirate or very difficult to do the cytology. So then we offer the patient with the confocal. And with the confocal, we could identify the papillary projection. So with this finding of papillary projection, it's very specific for IPMN. So then we decided to send the patient for pancreatectomy, and the surgical pathology confirmed IPMN with high-grade dysplasia. So that's the benefit of the confocal in real clinical practice in small indeterminate pancreatic cysts. So recent multi-center study from Ohio in 2019, Krishna recruited 144 patients, and they compare between confocal versus conventional method like a CEA or cytology. And the group demonstrated 97% accuracy from NCLE versus only 71% from CEA or cytology. So it shows clearly higher accuracy rate than CEA or cytology alone. So the similar results was confirmed in another study from another big group in European group published in the same year in 2019. Napoleon and his colleague as a multi-center study differentiate between mucinous versus non-mucinous with the accuracy 97 versus 78. And benign versus pre-malignant confocal 96 versus 84 of CEA alone. So it shows almost similar result, and there are also a few studies confirming higher results of confocal over conventional method. But in addition, we also would like to know that not only the IPMN that we can make an analysis, we also want to know that these IPMN became high-grade dysplasia or adenocarcinoma already. It became high-grade dysplasia or adenocarcinoma, so then we will go ahead and offer the pancreatic surgery to the patient with higher confidence. So this study, also multi-center study led by Krishna from Ohio, and I am also involved, and we published in 2019 in the same year. And finally, we can use we use several criteria, but the strongest two criteria were thickness of the papillary epithelium. If the thickness of the papillary epithelium is very wide, it suggested either high-grade dysplasia or cancer. And the second criteria that's very useful is the darkness of the papillary epithelium. If the papillary epithelium is very dark, so it suggests either high-grade dysplasia or adenocarcinoma. Also, we try to validate other criteria, but it's not as good as those two criteria. So in the conclusion, we have the area under curve of both strong criteria at 95 and 90. So so the confocal also add on of higher diagnostic accuracy in terms of it can differentiate between high-grade dysplasia and cancer versus the low-grade dysplasia. So that's why it becomes a very interesting test. So and they recently also there was a study to see the impact of the confocal on the therapeutic management of the single pancreatic cystic lesion. In the 206 patient cyst larger than 2 centimeters, they did the FNA and confocal. So significant change in therapeutic management in 28% and increase in the observer agreement of 0.28. and improvement of the full agreement rate of 24% and surveillance rate fell by 35%. So it impacts the management as well. So the third must-get here is EUS guided through the needle microbiopsy forceps. Let me show you an example of one of my cases. Again, the patient has a very small cystic pancreatic lesion. We try to do the biopsy, we found only 0 sanguinus. So then we pass the 19 gauge needle into the center of the lesions. We pass the microbiopsy forceps inside the 19 gauge needle. And then we open the forceps here, and then we grab the tissue and we pull back. And then the pathology from the microbiopsy forceps is cystadenomas. So it's very, it impresses us very much. So, and if we look at the literature, the recent systematic review recruit a nice study, 463 patients, cysts about 3 centimeters in diameter. The technical success of MBF was almost 100%. Tissue acquisition is about 80%, and the diagnostic accuracy was 70%. However, adverse event rate is about 10%. So, but anyway, the diagnostic accuracy is very high. Yeah. So how about if we compare between the microbiopsy forceps and confocal? There was one nice study from New York. It's a single-center retrospective study in patients with cystic pancreatic lesion who underwent both procedures in 44 patients. they demonstrate technical success was 100% for FNA, 88% for microbiopsy forceps, and almost 100% in NCLE. And of 44 procedures, there was only one adverse event from this study. So then, and they interpret result at the impact of microbiopsy forceps and confocal on pancreatic cysts. Look at the FNA or cytology alone, the impact for the treatment will be only 15%, and composite method is only 34%. But with the MBF is 75%, and confocal is 84%. So then clearly that confocal and MBF has impact to management of the cystic pancreatic lesion than the conventional method and FNA. So this is my last slide. I like to compare the three methods with conventional way. In my opinion, that for regarding the efficacy at this time based on evidence that I review, probably the confocal is the highest and slightly higher than the microbiopsy forceps, followed by molecular diagnosis and conventional way. And for regarding the safety, conventional and molecular diagnosis is safetiest, and confocal has a chance of complication around 3 to 5%, and MBF is around 9 to 10%. And for price, certainly conventional way cheap, molecular diagnosis is high, confocal very high, microbiopsy forceps is also high. So it's about 20 minutes already, so I like to end my lecture at this time. And thank you very much for your time. Thank you.
Thank you, Professor Kongam, very, very, very much for this excellent lecture, for so important problem, clinical problem in our everyday practice with the cystic lesions. Probably it's the most important and most frequent problem when it comes to the EUS and diagnosis. Thank you for this modern approach toward this problem, and we will discuss after the session. Now I would like to invite Professor Linda Lee, the Director of Endoscopy from Harvard Medical School. The subject of the lecture is Update 2021 on Contrast Enhancement, EUS and Elastography. Welcome, Professor.
Thank you very much. I hope everybody can see my slides. And great. And I just want to thank the moderators and the conference organizers for this invitation to speak to you guys about contrast enhancement, EUS, and elastography. So we'll start with a little bit of background. In terms of, for example, when we do physical exam of the abdomen, if we're trying to palpate for the liver, spleen, or masses, one of the things that we're trying to assess is how firm the tissue is. And that's pretty much what we're trying to do with elastography, except of course with EUS elastography, we're not literally palpating the tissue, but using the acoustic waves to help us to estimate the stiffness of the tissue. And the reason that this we believe is helpful is because various different disease states have different stiffness of the tissue associated with it. So for example, cancers are harder, firmer tissue as opposed to inflammatory conditions where the tissue is softer. And if you look at the EUS images on the bottom right there, you see a standard B mode EUS image showing a hypoechoic mass in the pancreas. And on the left, you can see the colorful imaging of the elastography. And you can see the rainbow of colors there on the bar, red and yellow representing the softest tissue, green, intermediate, and blue being the firmest tissue. Now, there are two different types of elastography. There's strain and shear wave. And in terms of strain elastography, the way that this works is by using the physiologic pulsations in the patient from their heart beating and their respirations, and then seeing how they impact your tissue of interest that you see in the left cartoon there. And as seen here, if the tissue is soft, you would imagine that that tissue would compress more in response. And you can assess that, with the ultrasound transducer. However, if the tissue is firm, like a cancer, it's not going to compress as much. The main limitation with strain elastography, though, is that it only measures the relative stiffness of tissue. It is not giving you the absolute value of the elastic property of the tissue. So in other words, it can be affected by various different things. So different patients, the physiologic pulsations are different. EUS transducer, one person may be pushing more firmly against the tissue than someone else. So that can all affect the values of strain elastography. Unlike shear wave elastography, which is different, as you can see in the right side cartoon there, the waves are being propagated perpendicular to the ultrasound waves coming from the EUS transducer. And so because of this, this is felt to be more objective potential measurement of the elastic properties of the tissue. And the faster the shear wave speed through the tissue, the harder the tissue is. You see some values there. And this is showing you, again, an example of strain elastography on the top EUS images. And because of what I referenced earlier with the subjectivity of looking at the various gradations of color, there have been attempts to try to semi-quantify strain elastography. One example being the strain ratio here. And how that is performed is you take your area of interest, draw a circle around it, and then you take a reference area. And the ratio of the two leads to the strain ratio. The higher the ratio, the firmer the tissue is. And contrast that to what we see during shear wave elastography, where you don't see all these lovely colors. Instead, you see this yellow rectangular box here around the area of interest. And typically when you're doing this, you want the lesion to be at about the 6 o'clock position from your transducer, about 5 to 10 millimeters deep. And then you take multiple measurements as seen here with the VS showing you the velocity. And then the right side column called VSN is actually a reliability index, basically telling you so-called how reliable your measurement is. And you want that to be as close to 100 as possible, which most of these values are. Now, shear wave is relatively new kid on the block, and there's very, very few studies looking at this. And in fact, there's a recent study that seemed to suggest strain was better than shear wave, but again, very early days for shear wave. And so most of the rest of my talk will be focused on strain elastography. So the qualitative EUS elastography, again, relies on the colors, and something that appears homogeneous green is felt to be normal, as you can see in the upper EUS image. Heterogeneous green with some yellow or red implies inflammation. Here in the middle EUS image, you see certainly heterogeneity of the green, maybe a few flecks of yellow and then blue scattered throughout. And you can tell why, because on the B mode imaging, you see the classic honeycombing that we think of with chronic pancreatitis. Now, heterogeneous blue with areas of green and perhaps red are indicative of cancer, as you can see in the bottom EUS elastography image, mostly blue, but there are certainly regions of green here. And then if an area is more homogeneous blue, if you look at this, again, bottom EUS elastography image and just focus on the blue area, that is felt to be more consistent with a neuroendocrine tumor. However, again, this is rather, this is obviously qualitative, looking at various gradations of the color and the heterogeneity. And the other thing to remember is that not an insignificant number of people are colorblind. And this, what I'm showing here is just one test for color blindness. So it's going to be obviously very difficult for those people to do qualitative EUS elastography. Now, one thing to know, I just want to reemphasize that strain elastography is, again, measuring the relative stiffness and not the absolute stiffness of the tissue. However, the attempts to semi-quantify elastography include the strain ratio that I discussed earlier, and you see various numbers there, representative of normal chronic pancreatitis and malignancy. And when you look at the top EUS elastography image, you see the strain ratio over 40, so very high, consistent with malignancy, certainly. Strain histogram is another way to try to quantify elastography, and this represents the color distribution through the lesion, as you can see in the bottom EUS elastography image. And basically, the colors are turned into a grayscale going from 0 to 255. representing the 256 tones. And when you look at the bottom right there, you can see that 0 corresponds to blue, so that's the firmest tissue. And on the far right, 255 is red, so that's the softest tissue. And here, everything is kind of clustered around the blue. You see many numbers here. One of the numbers that we focus on is the mean strain histogram. And the lower that is, the more concerning for malignancy it is. And unclear exactly what the best cutoff is, but likely, certainly less than 50, likely consistent with malignancy. And this is not used as much as the strain ratio. Now, I do want to show these 3 EUS images here. And if you look at the far left one, you see this hypoechoic mass on B mode imaging, and you see that the region of interest has been selected. And to the left, you see the reference area has been selected as well. And ideally, you want the reference area to be about similar distance from the transducer as the region of interest, as you see here. And the size of these 2 areas should be somewhat similar. And you can see that kind of in the middle EUS B mode image as well as the right as well. They're all kind of similar distance, similar size as well. However, you can see that the strain ratios vary greatly from 8.4 to 26.7, and this is all from the same pancreatic mass. So just re-emphasizing that this is rather subjective and very relative measurement. So in terms of clinical applications, of course, pancreatic masses, there's high sensitivity, although the main limitation is poor specificity. It's mainly helpful in ruling out malignancy, and it may also help you to target when you're doing your biopsy. So when you look at the bottom EUS images, the elastography shows a heterogeneous mass with some green areas implying softer tissue. So you'd want to avoid those areas and go after the blue area. And also, interestingly, studies have shown that the attempts to quantify strain elastography do not lead to any better results than the qualitative elastography. For chronic pancreatitis, strain ratio and histogram seem to correlate with the Rosemont classification and presence of exocrine insufficiency. And the top right chart is taken from one of these studies where you can see the strain ratio on the y-axis. And on the x-axis, you see the 4 categories of the Rosemont classification. And you can see that going from normal on the left to consistent with chronic pancreatitis on the far right, the strain ratio marches up there. One study suggested that a strain ratio over 2.25 was 91% accurate for diagnosing chronic pancreatitis. And when you look at the middle EUS image, on B mode, you might think that this is a cancer. However, when you do the elastography, it's heterogeneous, mainly green appearing with some blue, so more consistent with chronic pancreatitis. It may also be helpful with diagnosing AIP, because with AIP, you may see that the entire pancreatic parenchyma is diffusely stiff in appearance, as you can see in the bottom elastography image there. For lymph nodes, it can be helpful as well, as benign lymph nodes typically appear green, as you can see from the right elastography image there. Comparing EUS elastography diagnosis of lymph node to post-op histology, elastography was 94% accurate for diagnosing metastatic lymph nodes. And it may be helpful in allowing to select which lymph nodes to FNA. For example, when you're doing esophageal cancer staging and there's many lymph nodes, you can certainly do elastography and then try to target your biopsy to the stiffer lymph nodes. And also helpful if you just cannot do FNA for some reason. In subepithelial lesions, it may be helpful in differentiating GIST from other softer subepithelial lesions. You can see an example of GIST on the upper right EUS image, where it's again heterogeneous in appearance with mainly blue and green. And then the bottom image shows you an example of a leiomyoma that is mainly blue, although there's conflicting data on whether or not elastography is truly accurate in allowing you to differentiate leiomyomas from GIST. Focal liver lesions, it may be helpful, but we do need some further studies. And so in terms of the pros of elastography, it's very easy to use and learn, safe. You can do it real time, very quick to do. There's fair to good interobserver agreement, and I think it's useful in excluding malignancy. However, there's no standardized technique, and for both the qualitative and semi-quantitative elastography, it really kind of depends on the region of interest and the reference areas you're selecting. It's subjective. There's no definite cutoffs for strain ratio. As I mentioned earlier, how firmly you're pressing with your EUS transducer can certainly artificially increase the strain, and it remains unclear whether elastography improves outcomes of EUS or biopsy. So let's move on to contrast harmonic EUS. And I'll start off with a little bit of background here, where we're all familiar with Doppler ultrasound that allows us to nicely identify and see these large, fast-flowing blood vessels, but not so much the microvasculature going through tumors and other lesions, because the vessels there are small, have slow, low-volume flow. So enter microbubble contrast. When you combine that with sound waves, these microbubbles oscillate. They compress, they expand, and then emit acoustic signal that you can pick up with your EUS transducer. And so when you do contrast-enhanced Doppler, that did allow you to see these small vessels better, but there have been some limitations from artifacts and whatnot. And so contrast harmonic imaging is where you actually suppress the signals from all the background tissue and only enhance the tissues from the contrast agent. So when you look at the EUS images on the right, the upper one shows you your classic Doppler imaging, the middle one is contrast enhanced Doppler, and the bottom one is showing you that contrast harmonic EUS imaging. And you can see there this hypoechoic mass that's not enhancing with contrast. And also note that the resolution is poor with contrast harmonic EUS imaging, which is why you need this dual imaging with the B mode as well. So microbubbles, what are they? They're basically a stable shell that's encasing a heavy gas. And these microbubbles are more compressible than tissue. And as I already explained, how they react to sound waves. Mechanical index measures the acoustic power, which is the potential for the ultrasound to produce an effect on the tissue. And it's the ratio of the peak negative pressure with square root of frequency. And so at lower MI, the microbubbles will do what we want them to do to generate the image. But at higher MI, the microbubbles will just burst. You know, too much pressure and you'll just burst them. And so the goal is about 0.2 to 0.4. MI, and currently we're using the second generation microbubbles, Sonoview, Sonozoid, and Definity. Sonozoid is taken up by the Kupffer cells, which allows longer imaging duration than Sonoview, and I'll talk about that a little bit later. None of these are FDA approved for use except in cardiac and liver. The nice things about these is that they are filtered by the kidney, but eliminated by the liver, the lipid shell. So you can certainly use these in people with renal issues, and the gases are simply exhaled. Very, very safe with very rare anaphylactic reactions, and should not, the one thing is that you should not use these in patients with severe cardiopulmonary disease. So again, as I mentioned earlier, you want to be doing this dual imaging. And slowly, so once you've done your B mode imaging and you're ready to do contrast harmonic EUS, you slowly inject the contrast through the IV, followed by about a 10 cc saline flush. The initial phase of imaging, of course, will be the arterial phase, starting about 10 to 20 seconds after injection and lasting about 30 to 45 seconds. And then you'll go into the venous phase with some contrast washout going from about 30 to 120 seconds. It's important to assess the what's happening with the contrast in both the early and late phases as well. And quantifying would be good to do with things like time intensity curve or inflow time mapping, but I think we need more studies to try to figure out what's the best way to quantify. The bottom just shows you B mode imaging on the left, what it looks like pre-injection. During the arterial phase, you see hyper enhancement and then washing out in the venous phase there. So moving on to some clinical applications, we'll start with the pancreas again. And this year, the Asian Federation of Societies for Ultrasound in Medicine and Biology published guidelines where they recommended this for characterizing pancreatic solid masses because the data seems very positive. And a recent paper found that contrast harmonic EUS was better than EUS alone, in particular for diagnosing neuroendocrine tumors. but the diagnostic yield was similar to that of EUS-FNA. So in other words, it did not improve upon what we're already able to do with EUS-FNA. And they did quantitative analysis with time intensity curve and found that doing that was not statistically better than contrast, than the qualitative imaging. It does seem to be better than multi-detector CT and MRI for diagnosing early small pancreatic cancers. And you just see here on the right, hypoechoic mass, and after contrast injection, there's no enhancement there, it's hypoenhancing. Now, contrast harmonic EUS may help us to decrease the number of passes that we do to get a diagnosis. You see there a subtle, round, hypoechoic, mildly hypoechoic mass there. And then the middle image is showing you what it looks like after contrast injection. And you see this area where there's no enhancement on the upper left. And then in the bottom right, you see hyperenhancement. So that's really where you want to target your biopsy towards, not the area where it's avascular, which may be because of necrosis or perhaps desmoplastic fibrotic reaction. You already heard the great talk about vascular staging with pancreatic cancer, and it does seem, certainly contrast harmonic EUS does seem helpful in this, although I think we do need some more studies. Now, again, I just want to show you how the different lesions look different on contrast harmonic EUS imaging. So the top one is showing an example of adenocarcinoma, where in the early and late phases, there's no enhancement. The neuroendocrine tumor, as we all know, are hypervascular. And so as you might expect, you see hyperenhancement. And then the bottom two EUS images are showing you mass-forming chronic pancreatitis, where in the early phase, it looks like it's not enhancing, but as time goes by, you see some enhancement happening here, which you do not see with adenocarcinoma. So pancreatic cysts, the same guideline said that really for, there's limited yield at this current time for differentiating different types of pancreatic cysts. However, likely very helpful for diagnosing nodules. And this is from Mark Topazian's paper defining mucus versus nodule. And for the sake of time, I'm not going to spend too much time on this, but it's classic mucus is hypoechoic with a hyperechoic rim compared to nodule, which is iso or hyperechoic. And contrast harmonic EUS seems very helpful here. So when you look at the upper image, as you might expect, mucus should not enhance. However, a nodule will. And in fact, it also seems helpful in predicting the malignant potential of nodules, where the height of at least 8.8 millimeter for a nodule, you found that the contrast harmonic EUS was highly accurate at predicting malignancy, more so than EUS or CT. And this is a quick video showing you a cyst, and you see on the B mode something there, and you'll see as this is just the time showing you, the time after contrast injection. So not much yet, but then as time marches on, you start seeing a little flickering right here. And then by about 12, 13 seconds, you see this hyperenhancing here. So you know that this is not mucus, but in fact, a nodule. And an older paper did time intensity curve analysis that seemed to suggest that this can be helpful at differentiating high-grade dysplasia or malignant IPMNs from the low-grade dysplasia. And the bottom graphs are showing you the time intensity curve. And on the right side, you can basically see the yellow line where the nodule, there's very steep decline in the echo intensity change over time, unlike in patients with low-grade dysplasia. So for subepithelial lesions, it may be helpful in differentiating GIST from other lesions. You can see the upper image shows you an example of a GIST that hyperenhances, and there's a small area of non-enhancement in the middle of the GIST there, and also may be helpful in identifying the high risk and malignant GISTs as well. The leiomyoma, on the other hand, on the bottom you see there is not enhancing. Lymph nodes, the Federation did not recommend routine use of this yet. I think we need further studies. However, for the gallbladder, it may be helpful. in differentiating malignant, benign, and versus benign lesions. It seems better than B-mode EUS for diagnosing gallbladder cancer, as well as accurately diagnosing gallbladder polyps that are malignant. And the upper panel of images shows you a polyp, what looks like a polyp in the gallbladder, and you see it hyper-enhancing with time. This was an adenoma. The middle set of EUS images shows you an asymmetrically thickened gallbladder wall. And now with time, you see the middle contrast enhanced EUS image, the arrows pointing to some irregular vessels. And then later on, you see there's no enhancement there, as opposed to the rest of the thickened wall where there's hyper enhancement. So this is indicative of gallbladder cancer. Also, as you might expect, very helpful for diagnosing sludge. The bottom image, sludge has no vascularity, so there should be no enhancement, as you see down below. Now, liver, with Sonozoid, it is taken up by the Kupffer cell. So there's actually a third phase of imaging after arterial venous called the Kupffer phase. And this has been shown to be more accurate than B-mode imaging for diagnosing liver mets because there are no Kupffer cells in liver mets or hepatocellular carcinoma. And this is a recent GIE paper, their image showing you a very subtle hypoechoic mass with maybe a hyperechoic rim there in the liver, but with the Kupffer imaging, it just pops right out there because there are no Kupffer cells there, so there's no enhancement. And it was also very good at diagnosing small liver mets as well, and you can obviously use it to target that lesion for biopsy. So the pros of contrast harmonic EUS is that it's safe and easy. The AFSU-MB recommends its use in solid pancreatic lesions, staging, identifying mural nodules, gallbladder lesions, subepithelial lesions, and some liver lesions. Certainly seems better than multi-detector CT for diagnosing pancreatic cancer and chronic pancreatitis. It may increase accuracy by helping you to target your biopsy better. Now, some of the downsides is that there certainly is extra cost from the contrast agents, but then you have to weigh that against if you don't need to do another EUS because you got a diagnosis, perhaps, that works its way out. So we do need some cost effectiveness studies. There's certainly subjectivity from the qualitative analysis, and more studies are needed to optimize quantitative contrast harmonic EUS. And certainly at this point, it's not going to replace biopsy yet. Combination of both. When you look at the few studies that are out there looking at this, it's unclear whether doing both is better than either alone, although you might expect that it should be better. There was one recent study that showed better specificity with doing both for diagnosing pancreatic cancer. So in terms of my take-home points, these adjuncts to EUS imaging may help. Strain elastography is limited by subjectivity. Shear wave elastography may improve performance, although a recent paper suggested not, but we need further studies. It certainly appears useful for ruling out malignancy in pancreatic masses and may help diagnose AIP. Contrast harmonic EUS helps characterize and stage pancreatic masses and perhaps helps you to target your biopsy. It's helpful in identifying, predicting malignancy in mural nodules, likely helpful in gallbladder lesions and diagnosing liver mets. And we need some more work to optimize quantitative contrast harmonic EUS. So thank you very much for your attention.
Thank you, Professor Lee. We learned a lot about elastography and the contrast EUS from basics to clinical application. So let's move on to the next speaker, Professor Pierre Eisendras from Belgium. Hi.
Hello.
Hi, hello. How are you doing?
How are you? So you hear me well?
Yeah.
Okay, so I'll try to
Please,
share my screen.
Yep.
Sorry for this. You have my screen now?
Yes.
Is that all right?
Yeah, perfect.
Okay, great. So thank you very much for the invitation, and I'm always happy to join this teaching purpose congress, even if it's now a webinar. And I really hope that soon we will be able to join together and to go back to also the other important part of this really nice congress, which is the hands-on training. But as for the moment, we have to only discuss and show live case. My talk today is to share with you a more basic discussion about the place of sampling with EUS by doing FNA or FNB. So do we have to do sampling or not to do sampling? And this, as always, have to be considered as all our technique, whatever it's diagnosis or treatment, we have to consider it in facing the benefit and the risk of the procedure. And we know clearly that the benefit of doing FNA and FNB, it's having a confirmation of diagnosis for the patient, but also for the doctors, and maybe to take some management decision. And this is probably the most important thing. We have always to think that if we do something, it's that it will help the patient and it help the doctor to take a decision. Otherwise, if the act won't change nothing, we shouldn't do it. And why? Because on the other hand, there is the risk, and the risk is also the cost and the complication, the immediate complication, and we will also have a word about the seeding. Concerning the complication of the FNA, fortunately, it's quite a safe procedure, and we know that the risk by meta-analysis that we have is lower than 1%, with mainly a minor problem like chest or abdominal pain and acute pancreatitis in some cases after pancreatic puncture. But just keep in mind that these numbers, these figures, are mainly a mix of prospective and retrospective study, and in prospective study, these figures are slightly higher. And we know also that making puncture in pancreatic cystic lesion are associated with a higher risk of complication. So I would like to go through all the main indication, and we will speak a bit like Dr. Glees discussed before of some indication, mainly indication as a pancreatic mass, the cystic lesion, the subepithelial lesion. Also, what about the place of FNA in the luminal cancer evaluation? And finally, the lymph node of unknown origin. And I would like to see after each main indication, if there is an indication, in which case and when it's not indicated, and maybe where there is still a debate. So in the pancreatic mass, which is the first thing I would like to discuss, clearly, the image on the right side of the screen it's a cancer which is probably not operable, and we will need to do a puncture for sure to be sure that it's a cancer to send a patient for oncologic management. On the other hand, the left side, it's a really smaller mass which on the body of the pancreas, and maybe in this situation we may discuss the importance of doing a puncture before to send the patient for surgery. Well, firstly, we know all that surgery is the only way to cure this patient globally, but there is a new actor in the management of this patient, is the new neoadjuvant treatment, and this treatment helps most of the patient to bring them to a more resectable situation to offer eventually the surgery. And what is also interesting is that in this broad spectrum of type of lesion, resectable lesion, which before shouldn't be sent for neoadjuvant treatment, in some situations currently are indication when we speak about high-risk resectable lesion, example, high CEA 99 or extreme pain, etc., etc. So what I keep in mind after this the development of this neoadjuvant treatment is that the spectrum of masses that should be sampled for doing a neoadjuvant treatment is quite large, coming from locally advanced lesion, even metastatic lesion in some situation when it's the only way to obtain a sample, to borderline resectable lesion or even resectable lesion with high-risk features. And FNB should be certainly the most, the better choice if you have it. So what is the rest? It's the small lesion, which are suspected adenocarcinoma, which are possibly resectable without high-risk feature. In this situation, we can discuss And the two part of the discussion is, on the one side, if we are not doing the sampling, maybe we can send these patients to surgery with a risk of almost 10% of benign disease. That's what we look when we look to the surgeons' numbers. And this may be even higher in smaller lesions, smaller than 50 millimeters, where the percentage of benign disease may rise to 30%. On the other hand, if we do a sample, there is a risk of false negative, and there is also the risk of seeding. Concerning the performance of FNA and the risk of false negative, if you look to some small study, and the one of Figueiredo is from our center, we have a quite good sensibility and the risk of missing a cancer, so the negative likelihood ratio is really low. Unfortunately, if we look to the meta-analysis, these sensibility numbers are a bit lower, and there is a higher risk of missing a cancer. We have other means to confirm that it could be a cancer, as the one we discussed before, like the elastography or the contrast. However, if we are looking and speaking only about sampling, the suggestion of the DSGE is to re-evaluating the pathology slide if there is high suspicion for cancer and there is negative in the pathologic evaluation. Eventually, repeating the EUS guided sampling, or maybe in some circuits, send the patient for surgery directly. Concerning the seeding, well, the risk seems to be quite limited because we have only limited data and only case report. However, quite recently there was this study brought by a Japanese team, and in this, it's not a control study, prospective control study, it's a retrospective control study. But however, in the group of EUS FNA in the body of the tail of the pancreas where there was a cancer, they found in the 5 years follow-up up to 3.4% of patients with seeding in the needle tract. However, the recurrence-free survival and the overall survival was similar in the two groups. So I would like to summarize, to my point of view, in the future, almost all the suspicion, the solid pancreatic mass will be indication for, or are indication for doing a sampling. But there is still a debate, I admit, for lesion, which is obviously cancer, and masses of more than 20 millimeters. However, in my center, surgeon won't do any surgery before to have a proof that it's a cancer. The second group of lesion I would like to discuss is the pancreatic cystic lesion. We know that these lesions may appear with a lot of different aspects, and this is also due to the fact that the differential diagnosis behind these cystic lesions are quite enormous. However, we can probably limit it, the main diagnosis between these lesions, the mucinous lesion, like the cyst adenoma, the mucinous cyst adenoma, and the IPMN, and on the other hand, the serous adenoma and the pseudocyst. And we know that the EUS characteristics of these lesions, the EUS characteristics, are quite well available and easy to use. However, there is still a large mix, and most of the lesion, particularly the simple lesion, wouldn't be easy to delineate in these different differential diagnoses, except maybe for the IPMN, which is most of the time quite a classical appearance, like a grape-like shape lesion. However, for the ductal lesion, cystic puncture is obviously a good means to trying to delineate or to bring some clue to distinguish between mucinous and non-mucinous cysts. And that you know, and other chemical analyses like CEA, but also more recently, the place of low glucoses associated with the mucinous lesion. We can also send the patient for, yes?
So your slide offline, so can you share again?
Yes, for sure. I try again. Is it appearing really soon, or what was it just now, or?
Yeah, we just lost your slide, so
Just now, Pierre.
Okay, so I don't know why I'm not able to share again. I tried to do
Full screen, please. Full screen.
Yeah, it's what I do. Yeah, it's coming. Sorry. Is that going better?
Yeah.
Okay, sorry for that. So I just said that a chemical analysis may help to distinguish between mucinous and non-mucinous cysts, with CA analysis to be the first one to choose, but glucoses in the cystic liquid may also help to be distinguished between mucinous and non-mucinous, and particularly if a low glucose is observed, this is in favor of mucinous lesion. And then you may also do cytological analysis and also biomarker, including DNA-based biomarker like KRAS. However, if you look to the real-life performance of this cyst content analysis, and this is the experience given by De Jong, you see that the pathologic analysis is only helpful in these quite large series of more than 100 patients in 35% of the patient, and the biochemical results will help to distinguish the lesion in 56% only of these lesions, and this is size related. So finally, if you look to the recommendation of the ESGE, sampling is still recommended for doing a biochemical analysis and cytopathological examination if a precise diagnosis may change the patient management for sure, except for small lesion of less than 10 millimeters and with no high-risk stigmata, and CAs should be the first analysis, but I told you that the glucoses should be also evaluated. What about the branch IPMN? I told you that, to my point of view, most of the cases, the aspect of the IPMN is quite obvious, like in these cases where you really well seen the connection duct between the IPMN, which is already grape-like shape, and the connecting duct, which is the proof of an IPMN. However, the consensus of Fukuoka, the Asian consensus, was in favor of doing puncture sampling of this liquid of the branch duct IPMN, even without worrisome features, when you have a center with expertise in cytological interpretation, because you may see some clue or some sign of evolution of this lesion to a more aggressive aspect. So to summarize, pancreatic cystic lesion of more than 10 or 15 millimeters are almost always a good indication of puncture. It's not indicated in smaller pancreatic cystic lesion, and to my point of view, obvious IPMN, branch duct lesion, but this is debatable maybe. What about the subepithelial lesion? Again, a very heterogeneous group of lesions concerning the size, location, the clinical presentation, the fact that is this cystic or non-cystic. You have here the list of all the subepithelial lesions that you can consider in EUS. However, if I try to summarize how I'm deciding to do a sampling, I would say that globally, if I'm facing gastric lesion, I will be more prone to do a sampling compared to esophageal lesion, because there's in the gastric situation that there's a higher risk of having a problematic lesion, a lesion that can lead to a cancer or to a neoplastic transformation compared to esophageal lesion. Again, a large lesion will be more keen to be sampled compared to a smaller lesion, and less than 2 centimeters certainly, because the diagnostic lead for smaller lesion is lower. And again, on the opposite, an incidental lesion, incidental finding will be more prone to be sampled compared to a clinically expressed lesion, because a clinically expressed lesion will certainly send the patient for surgery. So the place of doing a pre-surgery diagnosis is not really mandatory. And superficial lesion, it's an option for other means of sampling compared to FNA, and that's what the ESGE told us, that there is also other technique to obtain diagnosis from cell, These are bite-in-bite, unroofed biopsy, or submucous resection. But however, I would like to remind you that now with the new sample, I should have written more FNB sampling. We have now with this new needle increased diagnostic yield compared with the FNA needle, and are much more keen to do a sampling with the FNB because we know that we increase the chance of having a good diagnosis when it's change the management of the patient. For sure, this is still the main motto. So to summarize, large, more than 2 centimeters, deep gastric asymptomatic subacute lesion are the perfect indication for doing a sampling. On the other side, I wouldn't do any FNA or FNB for cystic, certainly not, because there is a higher risk of complication if it's in the mediastinum, subacute esophageal lesion, and also it's obviously a lipoma or duplication cyst. What about the staging of luminal cancer? Globally, I will be more quick on that. All the situation, whatever esophageal, gastric, or rectal cancer, if there is lesion which are in favor of metastasis, liver metastasis, or metastatic lymph node, I will be more keen to do a puncture, also peritoneal like ascites. However, for the regional lymph node, for the rectum, there is no indication, and for esophagus, only limited for T1 and maybe T2, and certainly not if it's behind the tumor, because otherwise the sampling is of non-interest. And for the gastric side, no indication for regional lymph node except for T1. This is what it's summarized in this slide. Just to my point of view, a place for debate to do puncture of cervical or celiac regional lymph node, even in a T3 tumor, can be in an interest. I remind you that cervical and celiac lymph node are regional lymph node for lower and upper esophagus esophageal cancer, but it was before considered a metastatic site for cervical concerning the lower esophagus and opposite for the other one. And I think that in some situation, when it's a borderline situation to decide if the patient can be sent to first surgery or for a curative treatment, it may help to take a decision if there is a regional but far-sided metastatic lymph node. Finally, for lymphadenopathy of unknown origin, we know that EUS FNA and FNB is a higher diagnostic yield for that EUS alone to interpret these unknown lymphadenopathy. EUS FNA and FNB are safer than mediastinoscopy or surgical sampling for doing the access to the sampling, but EUS FNA is less safe and with a lower diagnostic yield compared to subcutaneous adenopathic resection. But what about the benefits, the diagnostic yield of EUS FNA FNB compared to mediastinoscopy or surgical sampling, where you can have a complete resection of adenopathy? We know that for these differential diagnoses that we can consider for this kind of lymphadenopathy, we have ancillary technique that helps to obtain, for example, the proof that there is a mycobacterium, or flux cytometry, and EHC for defining the type of lymphoma. But for the lymphoma, I was surprised preparing this talk that in fact, the diagnostic yield in some teams are quite high to confirm the lymphoma, over 80% or even over 90% for the last two publications. But also the lymphoma subtype identification may in some teams be obtained in 90 to 70% of the cases, which is to me quite high. It's not my experience, but I think we have to talk with our pathologists and our biologists to increase these diagnostic yield. And so to summarize, I would say that there is always an indication of doing a puncture or a sampling of these lymph nodes, except maybe if lymphoma is suspected and there is an easy access for underskin resection lymphoma. But if it's not accessible, then I think we should give a priority to EUS. Thank you very much for your attention and invite you to join us for our next Brussels meeting.
Thank you, Professor. Thank you for excellent lecture. To sample or not sample, so important for all of us in the practice. And let's start the discussion. We have about 12 minutes for discussion.
Can I ask a question?
May I ask a question?
Sure, please.
I had a question for Pradham Chai in terms of what is your practice with pancreatic cysts? What's your approach? Do you get molecular markers on every cyst that you're sampling? And then when do you decide to do NCLE or a forceps? Are you doing them on every cyst that's over 1.5, 2 centimeters in size? You know, how are you deciding your approach here?
Thank you, Professor Lindali. It's my honor to answer your question. So actually, it's not possible for us to do confocal in all cystic pancreatic lesions. We will do confocal in case that we think that it will change management of the patients. So most of the time, at this time, is indeterminate cystic pancreatic lesion. In some cystic pancreatic lesion that we know very well, that no worrisome feature, no high-risk feature, morphology shows small side branch IPMN, we're not going to do anything on that. Or in cystic pancreatic lesion, that's already well known from non-invasive image that it has solid component, it has mural nodule indicated for surgery. We will not do that. But in equivocal cysts, that sometimes patients come with the symptom suspicious of might be from mild pancreatitis, not sure it's pseudocyst or cystic neoplasm, and then the cyst is very small. So then in that case, we start discussion with the patient about the confocal or microbiopsy process or molecular analysis. But unfortunately, in Thailand, molecular analysis is very difficult. We still cannot send it for the complete set. So at this time, we have choice between do the chemistry analysis, which the yield is very low, right? And the second, cytology is very low. So then if I compare between microbiopsy process and confocal, this is on my only personal experience, I would prefer confocal rather than microbiopsy process in a small indeterminate cystic pancreatic lesion without nodule, without thickening wall. If it's more smooth wall, in my experience, confocal get a higher yield. But if the cyst has some solid component or mural nodule or thickening wall, probably microbiopsy forceps also provide a good yield as well. But I have the same experience as I gave my talk that probably microbiopsy forceps has a little bit higher chance of complication than confocal. This is to my experience only because information nowadays is very limited with the microbiopsy forceps. Did I answer your question?
Yeah, no, thank you. I really appreciate that. And I've had kind of similar, not great experience with the microbiopsy forceps. I mean, sometimes I get diagnosis, other times I don't. And I had a moderately severe pancreatitis happen to somebody, you know, who just had an incidental cyst. And I wonder if we should just use rectal NSAIDs, you know, on all these patients in the hopes that it might decrease, you know, post biopsy pancreatitis.
Yes.
And one more question, Professor, because we recognize pancreatic cysts so often in computer tomography. So for our audience, in my opinion, it's a very important problem. Do we should perform EUS in all patients with recognized pancreatic cysts in the pancreas, or only for them for biopsy? What's your opinion for our audience for everyday clinical practice of EUS?
Probably Pierre might be the right person to answer. Your talk is about FNA or not FNA, right? Yeah.
Yeah. So okay, thank you for giving me the chance to answer. I would just like to answer also the suggestion of Dr. Lee. I would be in favor of doing of giving NSAIDs, suppository NSAIDs to patients with a high risk of complication, like when you do a microbiopsy into the cyst. But well, there is no data about that. But this is my point of view. And concerning the decision of when doing a EUS or not for patient, again, I come with my motto I just said in my lecture. I think first we have to think if we will change something in the management of the patient. This is the first thing. And a lot of these patients are really old patients, and I won't consider to do a EUS directly, certainly, in this category of patient if there is no place for surgery. On the other hand, for younger patient or old patient with a possible benefit of surgery, it will depend of the size of the lesion and of the experience of the radiologist who do the MRI. I will rely on the MRI. So the question is more, should I do a EUS after my MRI, or just limited my the advice of my radiologist, and this will depend of the experience of the radiologist. We have excellent radiologists in pancreatic disease here in our center, and so if there is, I would say to resume that if it's a lesion of less than 2 centimeters with no high-risk stigmata on the MRI, even with a patient where there is an option of doing a surgery, I would suggest first to do a new MRI 1 year after and to see if there is an increase in the size of the lesion. And only if the lesion is increased, I will propose to the patient in EUS. For a patient with a lesion which is directly over this size, over 2 centimeters, I would suggest to combine the MRI with an EUS and potentially a sampling.
Thank you very much for this answer, the basic, in my opinion, because rather you qualify then when you have suggestion for biopsy, yes? And if it's not necessary, that rather MRI as the basic of to recognize the kind of symptoms. Thank you very much.
So Pierre, I also have a question. So when you perform EUS, like a 2 cm cyst, and then you decide to just follow up, what test do you use? Just MRI, or do you follow with the EUS? Which do you prefer?
You probably know that currently there are no global recommendation or consistent recommendation depending of which society you are looking at, Asian, American, European. You have different recommendation. We are still missing a good recommendation or a global consensus about that. I would say globally or traditionally, our way to do it, it's to, as I said, start with EUS, MRI plus or minus EUS, depending on the size. And after that, if there are no high-risk stigmata, going for follow-up by MRI and going for a new EUS if there is a change in size, or if there was a subtle lesion or a doubtful lesion at the first EUS.
Thank you.
And also, in some situation, also we will favor a followed by EUS if there is, for example, pancreatic familial history of pancreatic disease, because then I think we offer a benefit in the analysis of the parenchyma of the pancreas.
Like a small solid lesion, right?
And one short question for Professor Jan Genen for the first lecture, because it was very interesting, this puncture of the vessels, of the thrombus inside the vessel. In your opinion, is it safe? Because we also afraid when it comes to this procedure.
Yeah, indeed, this is not a routine practice. I personally perform it only in selected cases. And according to the literature, there are not so much reports about this technique. And there are at least some case reports that even after biopsy, some complications can occur, and theoretically, you can also cause bleeding or disseminating the disease and maybe sequential pulmonary emboli. But particular patients, also on the other hand, if patient needs, yes, it is safe according to the literature because very few adverse effects. But I cannot freely recommend it to everyone. But for selected cases, if you have to take biopsy, you can take it FNA from the portal vein thrombi. And I showed you one of the literature. It can upgrade or downgrade some of the patients. So it's important. If it is important for the patient management, then you have to do it. Like the cysts, if you need it, if it will change the patient management, I think we have to do it.
May I have one question?
Sure.
Sure. May I ask Professor Lee that in potentially resectable solid pancreatic lesions, when I think that you try non-invasive EUS procedure to make a diagnosis, but when
I cannot hear anyone.
will not believe that non-invasive technology, and you will go for the tissue diagnosis?
Yeah, so I think your question was if we're faced with what looks like a potentially resectable pancreatic mass, start with the non-invasive imaging, and if there's some kind of, you're not certain after the non-invasive imaging, then do biopsy.
Yeah.
And I think, so the issue with elastography alone is that the specificity is rather low. So I don't think you can rely on just elastography, certainly, if it looks like it might be a mass because of the low specificity still with elastography alone. I think with contrast harmonic EUS, it's better than the elastography alone. So if you have access to contrast harmonic EUS, and it's hypo-enhancing, during the early and late phase, and I think that's pretty reassuring that that's an adenocarcinoma. And as we talked about before, I think if the lesion is in the body tail of the pancreas and we're worried about, dragging the tumor cells through the stomach wall in somebody who looks potentially resectable, then maybe stop at contrast harmonic EUS. The issue, though, I'll tell you, and you obviously have to work carefully with your surgeons and see if they're comfortable with doing that, and so we have, close discussions with our pancreatic surgeons on, okay, well, we think this looks like a cancer. do you really want us to biopsy or not? Is it somehow going to help you? And as Professor Nakai said, if they end up needing neoadjuvant therapy or, afterwards they need therapy, which many more of these patients are, right? Like almost all of them are getting this nowadays. And I think the oncologists find it so helpful to have more tissue in order to do that, genetic profiling analysis to try to do personalized medicine on these patients. So, while yes, perhaps you can get away with the non-invasive imaging, I feel like because of the way the oncology field is moving and the way that we're treating these pancreatic, cancer patients is moving, you may still end up needing to get tissue.
Yeah, thank you.
Okay, so it's past midnight in Japan, so I want to go to bed. So let's close the session.
Time to party.
Yeah.
Thank you, everyone, and thank you for the audience to join this session. It's very exciting and very informative. So I want to close this session. So this is the end of the day. I'm not sure Mark wanna speak something or not. Mark, do you wanna close the day?
Sorry, I just come back from the endoscopic room. Okay, I changed clothes. Okay. What was your question?
No. I wanna close the session, but Maybe you
Sorry,
want to close the day?
okay. I think we had a full day with a lot of input about how to assess anatomy of the pancreas and the bile duct and the liver and the portal vein, and also about FNA and FNB, what to choose, and about also pancreatic cystic lesion and pancreatic tumor, solid tumor. So I just want to thank everyone because it was so interesting and so up to date also, and very didactic. So I just want to say to you, okay, see you tomorrow at 12 a.m. Maybe not the same hour in Japan and in Poland. I don't know, in Turkey and USA, of course, but in Brussels, Pierre, I'm sure this is the same hour. Okay. So again, thank you to everyone for your investment, and see you tomorrow, I hope. Okay.
Goodbye, Mark.
Yo,
Thank
bye.
you.
Bye. Bye.
Bye.
Bye.
Bye.